Hello, good morning. My name is Dr. Uma Borate, and I'm an assistant professor at Oregon Health Sciences University in our section for heme malignancies. Today, I'm going to be describing our data on our phase 1 study looking at the synergy between anti-TIM-3 antibody Mbg 453 and hypomethylating therapy. For those of you who may not be familiar with TIM-3, it's an inhibitory receptor expressed on macrophages, monocytes, and NK cells, and it is involved in regulating the innate and adaptive immune responses. It's expressed on myeloid cells, but also on leukemic stem cells and blasts, and not on normal hematopoietic stem cells. And that makes it a pretty promising target in both MDS and AML. In terms of the rationale for combining Mbg 453, this is a high affinity Ig4 anti-TIM-3 monoclonal antibody, which enhances immune-mediated killing of AML cells in vitro. And it does this by simultaneously targeting immune effector cells, as well as the leukemic stem cells and blasts. One of the more compelling things about the potential for combination of Mbg with hypomethylating agents in AML and MDS is the fact that we have preclinical data showing that there is upregulation of various immune-related checkpoint inhibitor type molecules with treatment with HMA therapy. And thus, we have several preclinical rationale that makes it a very attractive combination for synergy between the anti-TIM-3 antibody as well as HMA therapy. So our study looked at this combination in IPSS high or very high risk MDS patients, unfit AML patients ineligible for standard chemotherapy, as well as relapsed refractory AML patients ineligible for standard chemotherapy. We explored both hypomethylating agents, decitabine at the standard dosing, as well as azacitidine. The decitabine study started in August 2017 and has much more mature data than our azacitidine study, which started in February 2019. In terms of the Mbg dosing, we explored several doses and schedules. The most common schedules to be explored were adding Mbg to a combination with HMA on day 8 and day 22, so every 2 weeks, and also adding Mbg only on day 8 at a dose of 800 milligrams every 4 weeks. That every 2-week dosing, day 8 and day 22, we explored doses of 240 as well as 400 milligrams as well. What we saw in our patient population was, in terms of patient characteristics, is very similar to what you would expect for this patient population. We had all our MDS patients were high or very high risk by IPSS-R. They were older. Median age was over 72. Similarly, in high-risk AML, we had a majority of our patients belonging to the adverse risk AML population, about 57%, as is expected in an older patient population. In terms of our patient disposition, we think, based on our data now, we actually have evidence that this is a very well-tolerated combination. Median exposure for the decitabine arm was over 8.3 months in our high-risk MDS group and 6.8 months in our AML group. The azacitidine arm, as I noted, is still fairly new, and our median exposure is about 3 to 4 months in both populations. Importantly, none of the patients have come off therapy due to adverse events. About 22% of patients have come off therapy to receive a stem cell transplant, which is always great. And we have had some patients come off therapy due to disease progression as well. In terms of PK and saturation of the target using our monoclonal antibody, our results show that doses of about 240 milligrams every 2 weeks saturate soluble TIM-3, and modeling shows that 400 and 800 milligrams, 400 every 2 weeks and 800 every 4 weeks, are consistent with a greater than 95% membrane receptor occupancy in 95% of patients, and these were the most explored doses in our study. In terms of tolerability, we found that the most common reported treatment emergent adverse events were consistent with those that you see with single agent HMA, namely febrile neutropenia, thrombocytopenia, and anemia. We really did not have any treatment related deaths. We did not have an MTD as yet. And treatment discontinuation due to AEs, like I said, occurred in only 4 out of 106 patients. That's only 2.3% of patients. In this patient population, in this combination particularly, you really want to look at immune-mediated adverse events. What we noted was these occurred in very few patients, and they were predominantly low grade, so grade 1 to 2. These included some thyroid function abnormalities, some diarrhea, increased AST, ALT, as well as a rash and infusion-related reaction. The few grade 3 AEs, which included an AST and AST abnormality, as well as infusion reactions, did resolve with therapy or delaying treatment. In terms of responses that we saw with combination, in the MBG and decitabine combination, the overall response rate with high-grade MDS patients was about 62%. In the azacitidine combination was about 58%. With the newly diagnosed AML patients, our overall response rates were about 47% in the decitabine combination group and about 28.6% in the azacitidine combination group. The more important, or not the more important, rather something that we really want to know in these patients is what is the durability of this combination. And I think we're happy to report that this combination, again, appears very well tolerated and durable. The data we are focusing on is the MBG decitabine combination because this is a study that's been ongoing for the most time. We have patients in CR who are now have been on therapy for over 2 years. We've had patients progress to transplant. We've had patients that had hematological improvement and then continued on therapy with a variety of responses. As noted, all these patients appear to have high or very high risk MDS. The data is not mature in the azacitidine group, and the follow-up is also a lot less. The decitabine combination group, the time to response was about 2 months, which is encouraging, and the median duration of exposure for responders was about 8.7 months. So in conclusion, we do think that there is synergy between this combination. We think this combination with decitabine or azacitidine of Mbg 453 is well tolerated. Treatment-related AEs occur in very few patients, mostly low grade, and that there is promising anti-leukemic activity in patients with high-risk MDS. Overall response rates were about 61% in decitabine and 57% with azacitidine. The median onset of response was 2.1 months. We're also encouraged by the emerging durability seen in this combination in high-risk MDS patients with patients on study, responders on study for about a median of 8 months as of now. And because of these results, there are further studies planned with this combination in both MDS and AML, including a randomized phase 2, which is currently accruing, as well as a phase 3 study in the future. I want to thank everyone for listening to this presentation, and I am encouraged by the different options that we now have for our MDS patients with our various clinical trials. Thank you.